ladies and gentlemen. I hope you're all well and being safe and healthy during this unique time. It's certainly an honor to contribute to your education and help prepare you for yet another milestone in taking your exams. So this is Tom Graham from the Division of Hand Surgery, and I wanted to go over the topic of hand and wrist arthritis with you. Congratulations on everything you've accomplished during your time here. It's been extraordinary to see the growth, and I wish you all well in your careers. And as I'll reiterate, again, we're always here for you, and look forward to spending an entire career as your colleagues. Regarding hand and wrist arthritis, there's a lot of different ways to approach it. It's a super broad topic. I've tried to focus in on the things that I believe are the most important concepts and try to build around certain pathologies. There's certainly some things that get tested possibly out of proportion to their importance or the frequency with which they present clinically. I'm going to try to highlight that throughout in a way that's not as didactic. I know you have access to a lot of different course materials, and this is really a supplement and maybe something that will help some of these concepts stick in your mind. Therefore, I've not been exhaustive in what I've recorded here. I've tried to be as focused as I can, kind of make a few things memorable by highlighting some illustrative pictures or ideas or concepts. So I hope this style is something that helps these things become sticky in your mind. I kind of picked both the usual suspects and the things that over the years have been heavily tested. And this is just a little bit of a portfolio of those. So this laundry list kind of covers most of the things that I will be describing. And of course, there's a few things that I've added throughout. So essentially, I've tried to, when appropriate, kind of give the more general 10,000-foot overviews. Sometimes that includes some of the epidemiology on which you'll be tested. Obviously, mechanics and anatomy are critical, and the pathoanatomy, pathomechanics. There's a little bit about diagnosis and imaging when I think it's important and relevant. Obviously, when we're in the office or when you're going to be seeing your own patients, you're going to be going much deeper in that. But I, again, try to make this relevant and supplementary to the things like ortho bullets and some of the review courses you might be taking. I certainly probably have biased a little bit toward the operative treatments because that's what typically get tested, but never demur from picking a non-operative option if you think that that is appropriate. Complications, controversies. Certainly on the complication side, I've tried to elucidate some of those. I try to stay away from the controversies because if it's difficult for a bunch of hand surgeons to agree, I don't think that it's probably fodder for your testing. And then throughout, I've kind of dropped in a little bit of testing tips and questions. So let's first go over some of the epidemiology and more general concepts. Obviously, arthritis comes in a bunch of different flavors. Degenerative and post-traumatic are frequent in the hand. There are certain joints that are built to develop a little bit of arthritis, i.e. the basilar thumb, the small joints because of the force they take, and then obviously in pathologic situations, we'll dive deeply into some of the mechanics of the wrist. Although it's been largely almost eradicated, seemingly, inflammatory arthropathy in and around the hand and wrist has always been something that is both spectacular to look at, the deformed rheumatoid hand and wrist, and as a source of a bunch of questions. The way that it's being treated right now, we're seeing it less and less, but it's still an important thing to know about. I put congenital and idiopathic. Those are kind of a catch-all that I threw in there because there's a couple pathologies that may lead to arthritis or arthrosis, and I wanted you to make sure you had it. And for sure, crystalline arthropathy, maybe to a lesser extent, septic arthropathy. Just some general facts that seem to find their way to some tests. The DIP joints are very susceptible because of the high force transmission there. They may put in something like a dentist with, and then they'll go through because of the significant pinch power that's necessary. Thumb CMC, I think we all know because of the circumduction at the trapeziometacarpal joint is very susceptible to arthritis or arthrosis, and then the PIP joint often post-traumatic in some of the inflammatory processes, and then metacarpal phalangeal joint with its unique architecture for the hand is usually resistant to a lot of the degenerative changes, but is susceptible to the inflammatory changes. With regard to the basilar thumb, it's really pretty classic that it's a lot more prevalent in females. Older you get, chances are you're going to get it. And with regard to the small joint arthritis, nothing new there, and even in a greater proportion, male to female. Some more kind of random facts that may come up. It's probably going to be treated in some of my colleagues' work about fractures, etc. But I kind of threw some things in that, of course, we strive for anatomic reduction in everything we do, but we have investigated a little bit where we think the thresholds are for articular relationships and the potential for accelerated arthritis or arthrosis at the radiocarpal joint after intra-articular distal radius fracture. The popular number is 2 millimeters. It's 1 millimeter for both the distal radial ulnar joint, and interestingly, at the unicondylar fractures of the PIP joint, primarily 1 millimeter step off is thought to be deleterious and invite early arthrosis. Getting down to the wrist level, again, just kind of putting some numbers down on one slide so you kind of have them in your back pocket. Scapholunate gapping diastasis is something we look for. Again, that's going to be probably covered in the wrist instability talk, but around 3 millimeters, I get worried. 4 millimeters has typically been in the literature, the number over which that we are fairly convinced that there is a scapholunate ligament attenuation or injury. Of course, if it was in the clinical setting, you would want to take a look at the other side to make sure that's not how the patient was built. But in this particular situation, kind of keep that 4 millimeter number in mind. The distal radius can be deformed. It creates pain, limitation of motion, and sometimes can be thought of as accelerating early arthrosis when your typical volar tilt of the radial platform goes not only to neutral, but about 10 degrees into dorsiflexion. That is thought to be problematic. So just kind of remember that's a 20-degree displacement or deformity from its native position, which is typically about 10 or 11 degrees volar tilted. Radial inclination, or that kind of slide down from the radial styloid toward the distal radial ulnar joint, typically is in the 20 or 21 degree range. If that falls below 15 degrees, that's thought to be pathologic enough to cause difficulties, including potential arthritis. And then radial length is all over the place because everybody's built a little differently. Sometimes people are proud on the ulnar side, sometimes it's recessed. The idea is it's too controversial. I wouldn't necessarily think that that's going to be discussed or tested upon, but just be cognizant that radial shortening is deleterious, especially to motion. Let's go over the biggie. First, the degenerative changes that we might be seeing, whether they be primary or post-traumatic. I've kind of developed just a basic way of looking at it by joint, and put the hand first, and we'll look at the wrist second. I hope this format works for you. I've tried to give descriptions below. I hope they're not too verbose, but essentially, in your review, maybe you look at one slide a day or before you go to bed, and you kind of can imbibe that, and hopefully some of it will stick with you. A couple of things you're going to be looking for here is, you can see kind of bizarre deformities, but when you see so many small joints involved and the history doesn't have something that it's overtly talking about an inflammatory arthropathy, you can have extremely unusual looking joints. Look at the ring digit PIP. That can be very consistent with degenerative change. You see the sclerosis, joint space narrowing, osteophytosis in some of the joints, especially distally. Some of the soft tissue manifestations of hand arthritis of a degenerative nature are these lumps and bumps at the DIP joint known as Hebernan's nodes, and at the PIP joint known as Bouchard's nodes. I also included a ganglion cyst, or what we typically call a mucus cyst of the DIP joint. This is important for a couple different reasons, because they can, quote, leak under the nail fold, creating possibility of generation of aseptic arthritis at that joint. They can deform the nail when they encroach on the germinal matrix, and of course you look for that nail ridging. So this is just kind of an overall snapshot of something that with which you're undoubtedly familiar. We wear out at the small joints of the hand. It's a very frequent complaint. It's often bilateral. It's often in the index finger because of our pinch mechanisms. Probably not too much here. You might get asked about some of these soft tissue injuries, manifestations, and I don't usually go after Heberden's and Bouchard's nodes from a surgical perspective. I rarely, but I do every once in a while inject. Mucus cysts, especially when they attenuate the skin or have significant nail deformity, to me become a surgical indication, and they're excised all the way down to the joint level, taking care not to injure the extensor. Continuing on with this, usually the only thing surgically we can do for the very arthritic and symptomatic DIP joint is fusion. Most folks fuse them kind of straight using what you see here, which is a variable pitch screw. Obviously, you could try to shoot for a little bit of flexion, but that's going to probably require you using K-wires. Typical idea there: prepare the joint and you place it in whatever position you and the patient determined preoperatively. I have no problem fusing most DIP joints straight. PIP, little different. There is implant arthroplasty opportunities, yet I still favor PIP fusion, especially in the radial border digit or digits. You're pinching against these. Arthroplasty is a little bit too prone to complication, especially subluxation or dislocation. So I would probably say that fusion at the PIP joint is probably the more frequently elected procedure in the office, and probably should be the one that you would be thinking about first, unless they throw in some information like pianist, etc. You can place a PIP joint arthroplasty. They run the gamut from silicone to metal and plastic to pyrocarbon. And so for this, I would probably just say no, it is an option, probably a little bit more frequently used in the ring and small digit. Plus or minus in the long digit. Fusion still preferable for the index digit. And the position of fusion is a little bit up in the air. It used to be kind of sacrosanct at 20, 30, 40, 50. But again, clinically, you want to just restore the cascade. And I'm not sure they're going to ask you very specifically about a number, because it's a little bit determined at the time of the therapeutic dyad's decision to go forward with surgery. Some more stuff in the hand. Here we are at the MP joint. Remember, the MP is a very unique architecture. It doesn't have a lot of articular contact. It has a differential radius of curvature. So that's why, one, it can accommodate a lot of swelling in there if it's injured. It can often accommodate a lot of synovitis in an inflammatory process, but it isn't usually susceptible to primary degenerative joint disease. Can happen, of course, but when you see it, think of some other things. But if it's obvious and it hits you over the head, like I showed you in A, it does happen, especially in the index ray. I just included B because you can see head-splitting fractures of the metacarpal. They sometimes hide on an AP view, so an oblique especially, or a lateral view can be helpful. Just don't get tricked into looking at one view that points you down one direction of treatment when you can see something like this. The other thing is you can have surprisingly good function with translation of the MP fracture fragment. If it's still maintaining good articular contact, you may not need to do anything with it clinically, and I don't think it's going to probably be the fodder for a great amount of questioning, but I throw it in, again, just to kind of put something in your brain if you are seeing something unusual looking, especially on the oblique film at the MP level. Where a lot of your clinical practice is going to be focused if you're a hand surgeon, and a lot of the testing isn't around the basilar thumb. We just wear out there. I've never been a big person to use stages and classification systems. Just know what biomechanically is happening. It's a saddle joint. It doesn't have a lot of tight constraints, although the volar beak ligament and the dorsal ligament structures are important in stability in a traumatic situation. But we get a lot of circumduction out of the CMC joint, trapeziometacarpal joint. As such, when we're pinching, a lot of force goes through there. And what happens, it has a lateral subluxation that can be at issue. That creates a little friction at the joint. Obviously, friction in an articular surface translates to degenerative change. And we're typically looking at a reconstructive alternative for those that fail considerable and lengthy non-surgical treatments. So it's not something you jump right to a surgical treatment. Some of the differentiators that might be leading you one way or another in the treatment would be patient age and activity level. Young persons, construction worker, or super high level demand might be one of the very few patients in which you consider arthrodesis at the CMC joint. It is by far less frequently performed in a clinical setting. The gold standard, so to speak, has been a trapezium excision with some form of tendon interposition that can sometimes range from an attempt to reconstruct the ligamentous anatomy, but can be at times just a removal of trapezium and what's called hematoma arthroplasty, a terrible term. But the idea is the trapezium usually has 4 or 5 articular facets with its neighbors, and all of them typically go south. So when you see CMC arthrosis, there's probably STT arthrosis also. It's just something to think about. I put in B3 just because, in case there's something that's really leading you to want to preserve the joint and preserve the bony architecture of the carpal bones, but might reorient via an osteotomy, a closing wedge dorsal or extension osteotomy of the metacarpal. It's very infrequently done clinically, and I have seen it tested in the past. It's just not a path down which I believe they're going to lead you. Likewise, in B4, implant arthroplasty, the CMC, has uniformly been a disaster through my 30-year career and well before that. It's almost impossible to recapitulate the complex anatomy and motion. That's why it's very, very frequently performed. The complications, beside the usual infection, etc., perioperative complications, would be dislocation of the joint and bony erosion. I don't think you're going to be tested on that. If you are tested, it's probably going to be something along the lines of how complicated the procedure is. If you are asked what the kind of gold standard is, or you're asked for a treatment of run-of-the-mill garden variety CMC degenerative joint disease in the 68-year-old female, etc., you're going to probably want to say something that sounds like LRTI, which is ligament. It was trapeziumectomy with a ligament reconstruction and tendon interposition. Okay. Another place that has been a very fertile platform for testing is the concept of the programmed transmission of force resulting in arthrosis in and around the wrist after scapholunate ligament injury and the same mechanical problem, scaphoid non-union. So SLAC, scapholunate advanced collapse, or scaphoid non-union advanced collapse, SLAC, are really the same concept and mechanics, so don't get hung up on that. The idea is when you have an untethered scaphoid that relies on highly conforming relationship with the scaphoid fossa, when the struts and wires that hold our wrist in a very unique position to give us multiplanar wrist motion and keep the cartilage on compression, when you have scapholunate ligament injury, when you have secondary injury to the extrinsic volar ligaments, your problem starts to be a mechanical decompensation that results in high joint reactive force and shear along the scaphoid fossa and the scaphoid on the radial side. The first manifestation is usually a, quote, beaking, if you will, of the radial styloid. Then, as time progresses, you have a little bit more overall involvement of the scaphoid fossa of the radius. So here's a time where they do like to say stage 1, stage 2. And then the key is the next place that arthrosis manifests in the wrist after long time scapholunate instability or scaphoid non-union is at the mid-carpal joint. The lunate relationship with the radius is extremely accepting. It has a radius of curvature that accepts both the lunate because of the different radius of curvature, but just think about it, the reconstructive option of proximal row carpectomy, which we're going to go over in a second, the lunate fossa of the radius accepts the capitate. So just don't fall for the trap that says, oh, you're going to have arthrosis around the radial styloid and scaphoid fossa, and then it's going to jump over the crista or slight crest between those two structures on the radial platform and start to affect the lunate's relationship with the radius. That does not happen with frequency. It can, of course, but it's certainly not the more frequent manifestation of arthritis. The next place that arthritis occurs is at the mid-carpal joint, and it's going to be that determination of the quality of the capitate head that is going to point you toward one reconstructive option or another. So here you see the three most popular reconstructive. I don't want to leave out the distal radial ulnar joint. I think that it's important. Look at its relationship with the radius. Look at its relationship with the carpus, i.e. typically the lunate and maybe a little bit of the triquetrum, especially the triquetrum if there's a super long ulnar styloid in the very, very rare situation where you have abutment of the styloid with the triquetrum. But long story short is you can have degenerative change at the ulna. There's a bunch of different resections. The DERA, meaning just whacking off the end. There's matched resection. There's resections where you wad up soft tissue like the palmaris and you put it in there. There's just been a bunch of different stuff done. Take-home message is if you have significantly advanced DRUJ arthrosis, limitation of pronosupination, a lot of pain there, etc., you might consider this alternative. And the most frequently done, both historically and today, is some type of ablation of the distal ulna. If you have a perfectly good joint and it's just ulnocarpal abutment, you could shorten the ulna. That's probably left to another one of my colleagues' reviews. But just remember, if the joint is going to be okay and you're just beating up the triangular fiber cartilage, you may want to take off a little bit of the end of the ulna or the ulnar pole. That can be done open or arthroscopically, or recess the ulna through an ulnar shortening. Sorry to be digressing. Let's get back to DRUJ arthrosis. There is implant arthroplasty. You might be led down that path, albeit a rare option, if there was impingement of the distal ulnar stump on the ulnar border of the radius. That question would be accompanied by a radiograph that would show what I'll call scalloping on the ulnar border of the radius. And so it's just not something you're going to frequently encounter, but just think about ulnar implant arthroplasty as a potential alternative if you really, really think they're leading you down the primrose path. The procedure you see on the right is a salve, S-A-U-V-E, not suave, salve Capanghi, which is an arthrodesis of the DRUJ with the creation of a pseudoarthrosis by doing an ostectomy slightly proximal to the intracapsular or juxtaarticular margin. So it is used to support the carpus, typically in those patients who might also be having some ulnar translation of the carpus. So that might be the thing that tips you off, that they want you to support the ulnar column with a procedure like a salve Capanghi. So just consider it in your armamentarium and kind of just be knowledgeable that the patient will then get their pronosupination from the pseudoarthrosis creation. I guess I could have put these somewhere else, but I put them together just because they're kind of miscellaneous. But STT, scaphotrapezial trapezoid arthritis, just be knowledgeable that you can have isolated arthrosis there. In this particular example, I thought it was pretty interesting that the CMC joint looks pretty darn good. You might be asked about this. It used to be kind of a popular thing to do an STT or triscaphy fusion. Not so much anymore. Patients didn't like it. It was complicated. It didn't heal sometimes, etc. But I throw that out there because, again, when you're reading through the questions and you see an x-ray and something just doesn't kind of jibe, and then you see this, I want you to say, wait a minute, Doc Graham showed us something like that. Ulnar-sided wrist pain, again, is its own discussion, but for our purposes, you can have isolated piezotriquetral arthrosis. Sometimes they fell on an outstretched hand several months or years ago, and maybe they had an impaction type of injury at the piezotriquetral joint. The platform of the triquetrum got injured, whatever. Just know that the pieziform is expendable. You can take out somebody's pieziform. It's a sesamoid bone. You'd be shelling it out of the flexor carpi ulnaris as you would do with a paddlectomy, I guess. But the idea is watch out for it. It might be a bit of a red herring. People are not usually used to getting this projection and looking at the piezotriquetral joint. Just have it somewhere in the back of your mind. Now to inflammatory arthropathy, and I don't know why that didn't advance. Now it is. So here we go. Listen, if you were brought up in my era, you had to be a rheumatoid expert. This was super, super, super common. Now I'm worried that we're able to train our residents and fellows even in the concepts of rheumatoid mechanics, let alone surgery, because it's been so effectively taken care of by the chemotherapeutics. But here goes nothing. Do want to talk about the mechanics because I think if you understand that, you can answer any question, whereas sometimes people just try to memorize things around obscure problems like rheumatoid, and you end up getting confused. So I think if you teach somebody to fish, you're probably going to do better, and that's what we're going to attempt here. I'm going to throw in psoriatic arthritis too, because there's some very characteristic things that they just love to test on. This might be too much for some of you, and I understand that, but the concept is this. Think of all of the problems that an inflammatory arthropathy causes. Significant synovitis, weakness and attenuation of ligamentous structures, obviously primary degenerative, primary inflammatory, but destruction of articular cartilage. So what happens? Because the radius is inclined, right? We talked about that earlier with regard to fracture, and it's tilted volarward. The carpus slips down when you essentially attenuate the ligamentous structures, the extrinsic ligaments. So imagine your carpus is sliding ulnarward, ulnar translation of the carpus, which almost invariably is accompanied by a radial deviation of the hand-wrist unit. It doesn't. There's not a ton of motion between the proximal and distal rows of the wrist. There's almost no motion at all between the distal row and the metacarpals. So the ulnar translation is accompanied by radial deviation. However, because the extrinsic extensors and to an extent flexors have a pretty straight line of pull, it brings the metacarpal phalangeal joint into an ulnar deviated posture, apex radial. So this is the kind of Z deformity you see. Carpus slides ulnarward, radial deviation of the hand-wrist unit, metacarpal phalangeal joint is dragged into ulnar deviation. So this is an extremely typical kind of overarching way that rheumatoid can affect the hand-wrist unit. But it's very variable. It's because of the anatomy. It's because of the temporal way this disease can savage some individuals. And that's why you get stuff that's all over the board. On the left, you see a decent looking wrist, extreme ulnar deviation at the metacarpal phalangeal joint. On the right, you see a pretty straight metacarpal phalangeal joint, and the wrist is trashed. Just know that the inflammatory arthropathies have no specific pattern that they always follow. When you pop your scapholunate ligament, you're going to probably get radial styloid beaking, scaphoid fossa involvement, and midcarpal involvement with degenerative change. Period. End of report. Rheumatoid arthritis and its cousins, kind of the other seronegative spondyloarthropathies like sometimes psoriatic, but the arthritis and inflammatory bowel disease, etc. It can just be variable. Just be prepared to think it through. And again, going back to the basic tenets of the disease and some of the things we know from pathoanatomy and pathomechanics, we're going to come up with the right answers. The rheumatoid thumb gets a lot of ink. Remember what we said about the subluxation at the CMC joint with degenerative change. It can happen even more pronounced and sometimes more spectacularly with a rheumatoid change, where the CMC subluxates, you have kind of a collapse of the metacarpal, a compensatory hyperextension at the metacarpal phalangeal joint, which then requires the flexor pollicis longus to work overtime and flex the IP joint, the classic quote-unquote swan neck deformity of the thumb. Tough one to fix, okay? In general, when we approach the rheumatoid hand, we want to alternate mobile and immobile fused segments. This is no exception. However, in this particular situation, we may want to do a soft tissue arthroplasty to maintain some of the circumduction at the CMC joint, but fuse both the MP and IP, because what do we want? We want stable pinch, right? Now, I threw that figure in C to say that sometimes you just have to combat one joint. The IP joint, because it was working in pinch throughout the lifetime of the patient, can sometimes have a very significant apex ulnar angulation, and I think where there they want you to fuse it. This isn't something where you use an implant arthroplasty. You don't need mobility there. You want stability and strength. MP joint arthroplasty has been something that we've done over a long period of time. We were never convinced that synovectomy and extensor realignment worked for everybody. That being said, you might get a situation like in A where you say, wow, those MP joints look pretty darn good. There's a significant amount of deviation. The age of the patient is going to be young. That's going to be the rare circumstance where you may want to say, I get it. You want to maybe try to give this individual the opportunity to maintain some of their bony architecture. I'm going to try a tendon realignment with a synovectomy. Rare, but it might pop up. Again, just use the clues in front of you. Typically, you might see something like B where they might be giving you a little bit of a curveball. The MP joints look terrible. They're probably painful. We don't have a clinical picture. They might be significantly inflamed or swollen. But you're saying, well, geez, the ulnar deviation of the rest of the ray isn't there. They still want you to do something at the metacarpal phalangeal joint. What do? You typically do implant arthroplasty. You don't usually fuse the MP joint. It's not that popular. So implant arthroplasty, even in the index finger where you're going to be pinching, is a perfectly acceptable alternative. Gaining now into the, and by the way, I just threw that in there. That's radio opaque. Those radio opacities or grommets, they used to be very hep on asking whether they made any difference in the outcome, and they don't. So I doubt if that's going to be a part of the inquiry now for you. So a couple other ways digits look like. You might get a question about rheumatoid nodules. Rheumatoid nodules can kind of happen at any joint level. That's in contradistinction to the, quote, knuckle pad that happens almost exclusively at the PIP joint, can happen at the DIP joint, much more frequent at the PIP joint in Dupuytren's. So again, that line of questioning would be completely separate for you. But the idea here is these are rheumatoid nodules. Obviously, the patient would probably be described to you as having a history of rheumatoid arthritis. We usually observe them. You can inject them and you can take them out. You almost never take out a knuckle pad in Dupuytren's. And again, I'm sorry to mix the metaphor, but that's kind of the questions that are frequently asked. And you can excise a rheumatoid nodule, and you don't usually excise a knuckle pad. I think you all know this. Excuse me if I've insulted your level of sophistication, but boutonniere, swan neck, the boutonniere posture includes the PIP flexion and the DIP hyperextension. It's driven almost exclusively by problems of the PIP joint, whereas the swan neck, accompanied by hyperextension at the PIP joint and the reciprocal DIP joint flexion, can be driven from any level. DIP, PIP, MP. At the DIP level, if somebody is so inclined, i.e. a very lax volar plate, a mallet injury can have you result in a swan neck. Volar plate attenuation is almost always the germinal lesion. MP joint synovitis, etc. So boutonniere, PIP flexion, DIP extension driven by the PIP joint, and swan neck, kind of just the opposite, if you will, as you see, driven at any joint where pathology might occur. I said I'd throw something in about psoriatic. I think that you might see an x-ray. It would probably be either bizarro degenerative and inflammatory changes, or this, quote, pencil and cup. It's called arthritis mutilans for a reason. You can see almost anything. It can be, mostly eaten away. Psoriatic does weird things, but frankly, chances are they're going to show you a DIP joint. You can have fusiform swelling of the PIP also, but usually they're going to show you a DIP joint because of the pencil and cup. It might be associated with nail pitting, this oncodystrophy. So just know when you're seeing those things, they're pushing you towards psoriatic arthritis, HLA-B27. You get the idea there. The fusiform swelling that you see in C is usually characteristic of it too. However, I'm going to throw in an asterisk. Fusiform swelling, otherwise known typically as dactylitis, is highly associated with this form of inflammatory arthropathy, psoriatic. However, it is also a very painful condition associated with sickle cell. So if the patient's African American and they have significant pain, dactylitis, and are usually young, usually in the teens, really think about sickle cell. Okay? Here goes nothing. Congenital is a little bit of a reach, but allow me to use that to bring in Madelung so you have a picture of that in your mind, and then talk about the Osteonecroses, Kienbach, and Preissers. Madelung's is this physeal failure on the ulnar aspect of the radial platform and usually on the volar aspect. So geographically, on the ulnar volar aspect, there's a failure of growth. There can sometimes be a little bit of a bar, even a fibrous onlogen that grabs into around the lunate area. But this is highly characteristic. If you see a bizarre-looking X-ray with a super inclined radius, a pentagonal lunate that sometimes is falling into the DRUJ or what should be the DRUJ area, usually the radius translates volar on the stable ulna. This is Madelung's. Believe it or not, it's usually discovered spuriously, in another X-ray, or when a typically a 20-year-old female would be the history, comes into the office with vague wrist pain. One, this is why you always get this in Kienbach's, are the reasons you always get X-rays. But the idea is you don't usually have to get aggressive to treat it. I guess they could give you a scenario where you've tried repeatedly to treat it conservatively, but then it just didn't work. So I would probably say that the operative indications are going to be very rare, but put them in your back pocket as a possibility. Okay, Madelung's. Osteonecroses, the one everybody talks about is Kienbach's, lunatomalacia, or ischemic necrosis of the lunate. You worry about how to treat that but whether it's early and the lunate still looks like it has its external morphology and you treat that kind of like you would do a synovitis. Typically, this is associated with a lengthier radius, radial positive, ulnar negative. More force goes through it. You can see the lunate degrade. And then the big question is, if it's early enough and you can still save lunate architecture, should you do a radial shortening? If it's completely disintegrated, you may want to do a proximal carpectomy, etc. I think the questions usually go in and around recognition. Number one, the use of imaging. Don't be afraid to comment about getting an MRI, because sometimes in the early stages, the vague wrist pain with synovitis and a positive radius, the only diagnostic positivity you're going to have is with an MRI. And I usually just, and don't be afraid to shorten the radius, okay? That having been said, intracapsular problems need intracapsular solutions, and if the lunate is completely destroyed, they might be pushing you down to some kind of reconstruction like a proximal row carpectomy. I throw in Pricer's disease, avascular necrosis of the scaphoid for completeness. It's interesting. Usually we used to say that just quote unquote marbleizes the scaphoid. It looks really sclerotic, but it can create some degenerative changes. Also, just be cognizant of you can have an osteonecrosis of practically any joint. In this particular situation, it's the scaphoid, and it's associated with the name Pricer. I throw in crystalline arthropathy and a bit of septic arthritis just to remind you, because these go together in your differential a lot. Frankly, you've all been called down to the emergency room to see somebody with a quote-unquote septic wrist, and you ask, when was the penetrating trauma, or do they have an immunodeficiency? And the answer is no. Oh, by the way, they have a history of gout. Or just as frequently, it's going to be a pseudo-gout or a calcium pyrophosphate deposition disease. Just know that gout and pseudo-gout and septic arthritis are the interchangeable masqueraders, right? And you just kind of don't know typically until you recover fluid. And that's something you're going to just have to make some clinical determinations. And when you're taking the test, just be cognizant that when you see that blush of calcium pyrophosphate deposition, or you get a history, or you see tophaceous manifestations, they're trying to push you one way or the other. I threw in gout and pseudo-gout here, probably a little outside the purview of this particular talk, but I threw it in so you can just know what tophaceous change looks like. It's that toothpaste kind of caseous stuff. They ask a lot about the negative birefringence and crystalline needle-shaped crystals, etc., in gout, and the positive birefringence and the rhomboid crystals in pseudogout, etc., etc., etc. Here you see a little bit of a blush of radio opacity where you would anticipate the triangular fibrocartilage to be. That's going to be that calcium pyrophosphate deposition. The idea here is read the question twice for the clue that's going to tell you that it's either septic or non-septic. And if it's non-septic, you're going to be asked probably, what is the aspiration going to show? And they're going to describe either gout or pseudo-gout. I've listed some other things here. It's always an honor to work with so many accomplished people that are entering our specialty. I couldn't be prouder of you. And so I just want to tell you that you're going to do great. You've had great preparation. You're all, super geniuses as well as, technical masters. So, again, your progress and your growth is something about which you should be extremely proud. With regard to this test, you got this. Just go in with your logic and your systematic thinking intact. It's the answers are going to be there. The clues are going to be there, even in hand surgery. And we realize hand surgery itself can be extremely esoteric. And that's why we picked both common and somewhat complex and rare things to show you, just so you can say, oh, Madelung's, I get it. Pencil and cup, psoriatic. That's kind of that's kind of how I put this together. Long story short is I'm always available to you. That's my personal cell phone and my email. Good luck to you. Certainly, I hope that we all come through this immediate crisis happy, healthy, and stronger. But when you take your boards, keep in mind that we are all there behind you. Good luck and take care.